Welcome to the deep dive. Today, we're really diving into myasthenia gravis, or MG.
Yeah, it's a condition with a lot of layers.
We've gathered sources looking at everything, from the tiny details of the muscle attack right up to those critical moments in a myasthenic crisis.
hmm
So our mission here is to give you a structured, integrated view of this really complex autoimmune disorder. And if there's one thing to remember, it's this phrase, fatigable weakness.
That's the absolute hallmark.
Yeah, it's not just feeling tired. It's like you use a muscle, maybe chewing, maybe holding your arms up, and it just gives out dramatically.
And then with rest, it comes back, at least partially.
Exactly. It's this profound disconnect.
And that disconnect, it really points to the core problem. Myasthenia gravis, fundamentally, is a progressive autoimmune disorder hitting the neuromuscular junction.
That connection point between nerve and muscle.
Precisely. It's the communication across that tiny gap, the neuromuscular transmission, that's impaired. And the why behind it all, it's an autoimmune attack. The body makes antibodies against its own structures.
Against the muscle side.
Yes, on the postsynaptic side.
Mm-hmm.
The main target for most people is the acetylcholine receptor, the AChR. But we also see antibodies against other key players, like mesochromium muscle-specific kinase and LRP4.
So the body's own defenses are blocking the signals. What actually happens when those antibodies attach?
Right. So when they bind, they kick off something called the classical complement pathway.
Okay.
Think of complement as like an inflammatory demolition crew. It triggers inflammation, and it literally destroys parts of that postsynaptic membrane.
Destroys it.
Yeah, the intricate folded structure flattens out, and crucially, the number of working acetylcholine receptors just plummets.
So even if the nerve sends the signal perfectly.
The muscle can't properly receive it. There just aren't enough docking stations left. And that causes the weakness, especially the kind that gets worse the more you try.
Okay, that makes sense microscopically. So how does this show up in a, let's say, stable patient walking into the clinic? We talked about two main types.
Yes, ocular and generalized MG.
Right. Let's start with ocular. What does that look like?
Ocular means it's confined to the eye muscles. So patients report intermittent double vision, that's diplopia, or their eyelids droop, which is ptosis.
Intermittent is key, though.
Absolutely. It fluctuates. It's often worse with sustained visual effort, like reading or driving, especially later in the day. And it improves with rest.
And I read that even if it starts just in the eyes, it doesn't always stay there.
That's a critical point. A significant number, maybe around half, of those with initially just ocular symptoms will develop weakness elsewhere, usually within the first couple of years. That's when we call it generalized MG.
Okay, so generalized MG, that includes the eye symptoms.
Often, yes. The fluctuating eye symptoms continue. But now other muscle groups get involved, particularly the bulbar muscles.
Bulbar meaning throat and face.
Exactly. This leads to symptoms like a change in voice, maybe soft or nasal, that's hypophonia, or slurred speech, dysarthria, and really importantly, difficulty chewing or swallowing, which we call dysphagia. These bulbar symptoms can be incredibly taxing, making eating exhausting.
And then there's weakness in the limbs and neck, too.
Yes. And typically it's proximal weakness.
Meaning closer to the body's core.
Right. Difficulty lifting the arms, say to brush hair, or getting up from a chair, climbing stairs. It's often described as heaviness or fatigue, but it's painless weakness. That's key.
Painless. That helps differentiate it, I guess.
It does. And another crucial point for differentiation comes from the neurological exam.
How so?
Because MG is purely a problem at the junction. The nerve itself and the muscle fiber are okay. So sensation, touch, pain, vibration is completely normal.
Okay.
And also the deep tendon reflexes like the knee jerk, they're normal too. If you find sensory loss or absent reflexes, you're probably looking at a different disease.
Got it. So how do you confirm that fatigable weakness right there, during the exam?
Well, you demonstrate it. You might have the patient say, count out loud to 50 and listen for the voice getting weaker.
Makes sense.
And for the droopy eyelid, the ptosis, there's the ice pack test. It's quite neat.
Oh, yeah. Tell us about that.
You just place a bag of ice over the closed optotic eyelid for about 2 minutes. Cold temperature actually improves neuromuscular transmission slightly by inhibiting the enzyme that breaks down acetylcholine.
Acetylcholinesterase.
Exactly. So if the eyelid drooping improves even a little after the ice pack, that's a positive test. It's a quick bedside clue.
That's really clever. Okay, so you have clinical suspicion, maybe a positive ice pack test. What's next for nailing the diagnosis?
Then we move to more definitive tests.
Yeah.
First line is blood work, looking for those specific antibodies.
The anti-AChR, anti-MuSK, anti-LRP4.
Precisely. If those come back positive, especially AChR or MuSK, that pretty much confirms the diagnosis.
But what if they're negative? You mentioned ocular patients might be negative.
Correct. Antibody-negative MG does happen, particularly in purely ocular cases. So if antibodies are negative, but suspicion is high, we turn to electrophysiology.
Nerve tests.
Yeah, nerve convection studies, but with a twist. Repetitive nerve stimulation, or RNS. We stimulate the nerve repeatedly and watch the muscle's response.
And in MG.
You see a decremental response. The muscle's electrical output gets smaller with each successive stimulus. The signal is fatiguing.
Literally fading out.
Exactly. And the most sensitive test, though is more specialized, is single-fiber EMG, SFMG.
What does that show?
It looks at the connection to individual muscle fibers. In MG, you see increased jitter.
Jitter.
Yeah, it means the timing of the signal arriving at different muscle fibers within the same motor unit becomes inconsistent, asynchronous. It's another sign of unreliable transmission.
Okay, so diagnosis confirmed. Now, keeping the condition stable long-term, what's the approach?
Well, first, you want to improve symptoms day to day. That's where acetylcholinesterase inhibitors come in, like pyridostigmine.
The one the ice pack affects.
Right. It boosts the acetylcholine signal temporarily, but that doesn't fix the underlying autoimmune attack.
So you need immunosuppression.
Yes, that's the cornerstone of long-term management. It's about calming down that misguided immune response.
And there are quite a few options there, aren't there?
There are. It often starts with corticosteroids, like prednisone. Then we add or switch to non-steroidal immunosuppressants to allow for lower steroid doses long-term. We've got drugs like azathioprine, mycophenolate, others like cyclosporine or tacrolimus, and increasingly targeted therapies like rituximab.
Rituximab targets B cells, right?
Correct. And for really tough refractory cases, especially AChR-positive ones, there are even newer agents that block that complement cascade we talked about earlier, like eculizumab.
Wow, lots of tools. Now, we absolutely have to discuss the thymus gland. It seems, well, central to this.
It really is surprisingly central for many patients. The thymus, this gland in the chest, seems to be where the immune system often learns to mistakenly attack those ACA receptors.
So everyone with MG needs chest imaging.
Absolutely. CT or MRI of the chest. We're looking for thymomas, tumors of the thymus, which occur in a fair number of MG patients.
And if you find a thymoma,
It has to come out surgically, unless there's a major reason not to.
but even without a tumor, thymectomy is sometimes recommended.
Yes, that's right. For patients with generalized MG who are AChR antibody positive, even if they don't have a thymoma, removing the thymus gland thymectomy is often considered, especially in younger patients.
Why?
Because even a non-tumorous thymus can be hyperactive and contribute to the autoimmune process. Removing it can lead to improvement, sometimes significantly, and might reduce the need for long-term immunosuppression.
Okay, that's the stable picture. But then there's the crisis. Myasthenic crisis. That sounds serious.
It is. It's
Oh.
life-threatening. It's defined specifically by respiratory failure due to MG weakness.
Respiratory failure. So immediate action needed.
Top priority, ABCDE assessment, airway, breathing, circulation, disability, exposure. If the patient is unstable, particularly struggling to breathe, securing the airway is paramount.
So intubation might be needed right away.
Often, yes. Or sometimes non-invasive ventilation like BiPAP and bridge. But you have to be ready to intubate. You can't afford to wait.
What are the warning signs? Besides just shortness of breath.
Rapidly worsening weakness everywhere. Difficulty swallowing becomes extreme, maybe choking, drooling. The voice might be barely audible. Speech, very slurred.
And breathing-wise?
Look for shallow, rapid breathing. And critically, look for paradoxical breathing.
What's that?
It's when the abdominal wall moves inward during inspiration instead of outward. It means the diaphragm is severely weakened and failing.
That sounds like a really bad sign.
It is. And a word of caution. Don't be falsely reassured if you don't see accessory muscle, neck muscle straining. If the patient is globally weak, they might simply be too weak to use those muscles.
Terrifying. What usually triggers a crisis like this?
Often there's an identifiable trigger. Infection is a big one. Pneumonia, UTI, recent surgery, the postpartum period. And crucially, medication issues. Tapering immunosuppressants too quickly or starting certain new medications.
Ah, yes. The medication list. That seemed important.
Extremely. There's a list of drugs known to worsen MG or block neuromuscular transmission. Things like magnesium infusions, botulinum toxin, certain muscle relaxants, beta blockers, and several classes of antibiotics are notorious. Aminoglycosides like gentamicin, fluoroquinolones like ciprofloxacin, and macrolides like azithromycin. You have to check the patient's medication list carefully.
Okay, so you suspect a crisis. How do you objectively decide if someone needs intubation before they completely crash? You mentioned you can't wait for blood gases.
Correct. Waiting for CO2 to rise or oxygen to drop on an ABG is waiting too long. The key is bedside pulmonary function tests, PFTs, specifically measuring muscle strength.
Right, the 20, 30, 40 rule. Let's break that down. Okay, so
Yeah.
intubation is strongly indicated if, number one,
Vital capacity, or VC, the maximum air they can blow out is less than 20 mmol per kilogram of ideal body weight.
20. Okay, number two.
Maximal inspiratory pressure, MIP, or NIF, the force they can suck air in with, is less negative than negative 30 centimeter H2O. So
Yeah, weaker than negative 30.
less than 30 inspiratory. And third,
Maximal expiratory pressure, MEP, the force they can blow air out with, is less than 40 centimeter H2O.
40 expiratory. So 20, 30, 40, VC, MIP, MEP. That's the threshold for intubation.
That's the guideline, yes. It helps make the decision proactively.
And once you've stabilized the airway, what's the acute treatment for the crisis itself?
You need to rapidly reduce the antibody attack. The two main options are plasmapheresis, or PLEX.
Which cleans the antibodies out of the blood.
Exactly. Or intravenous immunoglobulin, IVG, which provides healthy antibodies to sort of modulate the immune system. Both work reasonably quickly. You also usually start high-dose corticosteroids, but with a bit of caution.
Why caution? Because sometimes, in the first few days, high-dose steroids can paradoxically cause a temporary worsening of weakness before they start to help. So you monitor closely.
And treat the trigger, right, like the infection.
Absolutely essential. Treat the underlying cause, like giving appropriate antibiotics, ones that are safe for MG patients, of course.
This brings up a really tricky point. What if the weakness and breathing trouble aren't from the MG getting worse, but from too much of the treatment medication?
Yes. The cholinergic crisis. That's the flip side.
Thymectomy myasthenic crisis.
It can look very similar: severe weakness, respiratory distress, but it's caused by an overdose of those acetylcholinesterase inhibitors, the pyridostigmine, or sometimes by poisoning with similar compounds like organophosphate pesticides.
So how on earth do you tell the difference in an emergency?
You'll look for signs of excess acetylcholine everywhere, not just at the muscle junction. There's a mnemonic, SLDGE.
SLDGE, okay.
S for salivation, L for lacrimation, tearing, U for urination, D for defecation, G for gastrointestinal distress, cramps, nausea, and E for emesis, vomiting. Basically, the body's fluids are in overdrive.
That sounds messy. Is there one key physical sign?
Yes. The pupils. In a cholinergic crisis, you typically see pupillary constriction, pinpoint pupils, or miosis.
And in myasthenic crisis?
Pupils are usually normal in a myasthenic crisis. That pupillary finding can be the crucial differentiator. Get it wrong, and you might give more medication when you should be stopping it, or vice versa.
Wow. Okay, so wrapping this up for everyone listening, we've gone from the tiny autoimmune attack at the receptor
To the patterns of weakness, that fatigable nature, worse with use, better with rest.
talked about the thymus connection, the specific numbers, that 20, 30, 40 rule for breathing support.
And even how to spot the difference between too little medication causing a crisis and too much.
It really highlights how you need both, like close clinical observation, noticing that paradoxical breathing, doing the ice pack test.
Combined with those very specific measurements, like the PAT numbers, to manage something that's always changing. It's complex.
It really is. And that point about common medications, like certain antibiotics being potential triggers for a crisis,
Yeah.
it leaves us with a pretty important thought, doesn't it? How absolutely vital is getting a complete, detailed medication history, every single pill, supplement, everything, when someone with a known autoimmune condition like MG comes into the hospital.
It's critical. That conversation could literally be the difference between stabilizing someone and accidentally making things